The Diabetic Foot, preventing foot amputations one step at a time. This is Janet Spray. The health risk identified is diabetic foot amputations. It is estimated there are nearly 26 million people in the United States with diabetes. Diabetes has now been reported to be in epidemic proportions across the country. Diabetes is a very serious chronic disease, which is the leading cause of foot ulcers and amputations. Persons with diabetes face an almost 30-fold increased risk of lower extremity amputation. 85% of amputations are preceded by non-healing foot ulcers. Foot problems are the most common cause of hospital admission for people with diabetes. The rising epidemic of limb loss is largely due to diabetic foot ulcers. Common diabetic complications such as peripheral vascular disease and neuropathy are the main reasons for foot ulceration. Structural deformity, wearing inappropriate footwear, and having poorly controlled diabetes also contribute to diabetic foot ulcerations. Goals for public health nursing should be to raise the awareness of the diabetic foot at risk, to persuade healthcare decision makers the importance of amputation prevention measures, and to inform people with diabetes of the measures that they themselves can take to prevent foot complications. It is essential to utilize an interdisciplinary team approach to reduce amputations in people with diabetes. At the time of diagnosis, the medical team, along with nursing, podiatrists, and nutritionists, should focus on controlling blood glucose levels to prevent complications that arise from the disease. One should have a foot screening yearly to determine if neuropathy, which is identified with a loss of protective sensation, or if ischemia or poor circulation is present. When loss of protective sensation and/or ischemia arises, foot ulcers are more common. Once a foot ulcer is present, wound care specialists, infectious disease specialists, vascular and orthopedic surgeons, along with podorthics, become involved in hopes of preserving the foot. This is an example of the lower extremity amputation prevention foot screening from the U.S. Department of Health and Human Services. This foot screen uses a 5.07 monofilament which delivers 10 grams of force to identify patients with the foot at risk for developing problems that can lead to amputation. The red areas on this foot screen show where to apply the monofilament. Screening should be performed on all patients with diabetes annually. This foot screening can be used in any clinic, provider office, or community health fair as a primary prevention plan in reducing amputations by identifying feet at risk. When using the LEAP foot screen, the risk category 0 shows no loss in protective sensation and recommends that the patient be seen again annually for follow-up and as necessary. Risk category 1 shows at least one area of the foot with loss of protective sensation. These patients should be seen at least twice yearly for follow-up. Risk category 2 includes loss of protective sensation, but also includes bony deformity or poor circulation. These patients should be seen every 3 months for follow-up. Risk category 3 is the highest risk for amputation. Monthly follow-up is recommended. Ongoing care is needed for this risk category to preserve what part of the foot they have left. Treatment plans for each category include: Category 0 includes patient education on foot care and footwear, routine care is needed, and annual follow-up for rescreening. The treatment plan for Category 1 is the same as Category 0, except they are usually prescribed soft molded insoles to prevent ulceration where they have a loss of protective sensation. These patients are seen twice a year for follow-up. Category 2 is a high risk for foot complications. Patient education, proper footwear with possible modifications, scheduled routine foot care, daily self-inspection is required by the patient. Custom molded shoes or inserts are often prescribed, and these patients are to be seen every 3 months. The highest risk for foot complication leading to amputation is risk category 3. These patients are to be seen monthly and have the same treatment as risk category 2, except they are to be seen monthly and they usually receive special shoe modifications such as a rocker bottom shoe. Ways to prevent foot ulcers include keeping blood glucose in good control, usually having your A1C below 7, exercising and not smoking to keep circulation strong, inspecting feet daily, wearing appropriate footwear at all times, not going barefooted, to see a foot specialist yearly to identify a foot at risk and then be seen as Recommended. Rapid treatment of all foot problems immediately whenever a foot problem occurs to seek rapid treatment, and education for people with diabetes on how to take care of their diabetes and their feet, along with education for healthcare professionals on how to maintain proper foot care and footwear for the patient with diabetes. Our primary prevention plan is where we can most likely reduce the number of diabetic foot amputations. The primary prevention plan will include primary care providers, podiatrists, nutritionists, and nursing caring for the person once the patient has been diagnosed with diabetes. They will become involved with planning and implementing our plan. The primary provider, nurse, nutritionist, podiatrist shall complete an annual diabetic foot screen like the LEAP diabetic foot screen we've seen in the previous slide. This screen will determine appropriate follow-up at diagnosis and thereafter. Diabetic foot care management and proper footwear selection shall always be enforced. Risk Category 2 is our secondary prevention plan. Disciplines involved in implementing the secondary plan of prevention include the primary care provider, the nutritionist, the nurse, podiatrist, and now a podorthist. In secondary prevention, a podorthist or shoe specialist is consulted to make custom molded insoles with modification to relieve areas of pressure to prevent ulceration. The patient is also empowered to check feet for redness, sores, blisters at least twice daily. In tertiary prevention, the team will now include wound care specialists, vascular and orthopedic surgeons, and infectious disease specialists to either help heal a wound, improve bony deformities, or improve circulation. Tertiary prevention is the last hope for limb salvage. The interdisciplinary teams must work very closely together with the patient to help prevent limb amputation. Diabetes is a multifactorial disease process, and as a consequence, the greatest successes in the management of these challenging patients come when providers work together to provide comprehensive care. Leadership qualities the DMP needs to develop and implement the plan is communication. Communication with the patient and healthcare providers is necessary to empower the patient to take a more active role in their management and follow-up as needed. Communication to clinicians to perform the diabetic foot screening and risk stratification among these patients and triage high-risk patients towards appropriate and timely interventions can limit the comorbidity and mortality associated with lower extremity amputation. The DMP can ensure that communication among the interdisciplinary teams is essential to improve limb salvage. The DMP must also effectively delegate care for the patient to the appropriate interdisciplinary team for the appropriate interventions based on the risk category. By speaking to the healthcare professionals directly regarding their position to perform diabetic foot screening is a direct delegation example. By communicating with insurance companies, hospitals regarding their policies and standards for implementing diabetic foot screening can be an example of indirect delegation. Empowerment is another leadership competency the DMP needs to effectively develop to implement the plan. Patients need to be empowered to take action to inspect their feet daily, wear proper footwear, and not go barefoot. Empowering the patient is the best preventive measure in preventing foot amputation. The DMP will also need to empower the nurses, podiatrists, nutritionists, and primary care providers to perform the 10-gram filament foot screening to assess a foot for risk. Empowerment makes the team more responsive to our identified health risk. Prior to the plan implementation, the data from these databases regarding diabetic foot amputation incidence and prevalence will be recorded and studied. About a year after our plan has been implemented, the APEX, PH, and MAP data can be looked at regarding the county data and amputation prevention. If certain hospitals and clinics are participating, their data can be used to determine the success of our program. National trends can be followed with local trends. Data can be looked at through the state to see what measures are being taken to reduce diabetic foot amputations. Professional education programs, establishment of local diabetes coalitions and diabetes support groups, along with providing provider education workshops on the diabetic foot care management and amputation prevention, can assist in helping our plan be a success. It has been shown that diabetic foot screening, which identifies a foot at risk, can prevent amputation. For effective preventative care, patients need to understand how diabetes impacts health and what measures they need to take. Foot care management requires a multidisciplinary team approach. Health programs build stronger communities when community people become involved in making decisions about suitability of resources. This encourages community ownership of health promotion interventions. Through communication, delegation, and empowerment, the DNP can play a vital part in developing and implementing our interdisciplinary plan to help prevent lower extremity amputation. And these are our references, and we hope we can prevent amputation one step at a time.